single vision. So the contents are definition, advantages of binocular single vision, grades of BSV, mechanism of BSV, theories of BSV, and abnormalities and stereopsis. So the types of vision are monocular vision, which is vision with a single eye; biocular vision, which is vision with two eyes, but there is no coordination between them; and binocular is coordinated vision from the two eyes. So monocular vision is one eye seeing the object from its visual axis, and other eye is also seeing the object from the visual axis, which passes from the object to the fovea and which passes to the nodal point of the eye. So the definition is the state. It is a state of simultaneous vision with two seeing eyes that occurs when an individual fixes his visual attention on an object of regard. So it is the ability to use both the eyes simultaneously, so that each eye contributes to a common single perception. Normal binocular vision is bifoveal and there is no manifest deviation, which means that the image of the both eyes should form on the fovea of the two eyes, and there should be no squint present in the vision. So this is the image seen from the one eye is a single hexagon, and from other eye also a single hexagon. And when the both eye fuses, then it seems like it seems as if a cyclopean eye is in the center, and then both the eyes also see a single image. So the requirement for the normal binocular single vision is proper alignment of the eyes, means there should be no squint, equal image clarity, which means there should be no significant reflective error, cataract, or corneal opacity in one of the eyes, and there should be presence of sensory and motor fusion. Advantages of binocular single vision are it provides a single vision, stereopsis, masking of the optical defects and the blind spot, and a larger field of view. So the field of view from one eye is this, and from the other eye is this, and when they superimpose, then we have an extra field of view, which is this. And the stereopsis is the most precise kind of depth perception. Both eyes are simultaneously used. So in exotropic eyes, the field of vision is larger. So optic nerve, how it masks the optical defects and blind spot as the optic nerve is passing nasally. So the scotoma, for example, the right eye scotoma will be temporally seen, and left eye scotoma will be here temporally seen, but we don't see the temporal scotoma in normal day-to-day life because the normal nasal field compensates for the scotoma of the other eye. So one eye compensates for the defect of the other eye. Then the word screen of binocular vision, it helps in identifying degrees of binocular single vision. First is simultaneous perception. It is power to see the two dissimilar objects simultaneously, and it sees this only when we suppress the image from one eye at our own will. Then fusion is it is ability to produce a composite picture from two similar pictures, and each of which is incomplete in some small detail. Then stereopsis. It is ability to obtain impression of depth by superimposition of the two images of the same object when seen from two different slightly angles. Binocular fixation versus uniocular fixation. Both eye, so this is the both eye together image is formed at the fovea, and one eye looks somewhere else, so this is the uniocular fixation. Then the mechanism of binocular vision: visual direction, retinal correspondence, or optic and Hammond's fusional area. Visual direction: when the retinal area is stimulated by light from object. So the stimulus is perceived not only of the certain color, brightness, or form, but also it is localized in certain direction in the space, for example, temporal, nasal, superior, or inferior. So, for example, here is the object and it stimulates the retinal area on the left side of the fovea, so image will be formed on the right side, and vice versa. If the object is here and it stimulates the right side fovea, image will be formed on the left side. Then the retinal elements. Each and every point on the retina has an intrinsic direction associated with it, and the direction in which the object is localized is determined by the direction or spatial values of stimulated retinal elements. So the spatial orientation or the directional value in the visual field is an intrinsic property inherent to the individual retinal element of retina, and it is known as local sign of Lorentz and help to localize various objects. Then the retinomotor value. Every retinal element has a retinomotor value, and the value of the retinal decrease from the center towards the periphery because the eye has to move more in order to bring back the fixation to the fovea. So the value of the fovea itself is 0 because the eye does not move in that case. And clinical significance is it helps in measuring ocular deviation by means of the prism and cover test. So here the image, the eye moves and the image then forms on the fovea. Then the visual space versus the physical space. So visual space is the subjective space that is based on anatomic and physiological system, visual cues and on learning, which means whatever we are seeing when many objects are present. And physical space is the actual space of the object, whatever the object is occupying. Anatomic distribution of the retinal elements doesn't coincide with the physiological distribution of spatial values, which is Kant's Munsterberg illusion. So, location of the object is its physical space, and localization of the object is its visual or subjective space. Then the common relative subjective visual direction. So, this is the fixation point, and both the eyes, these are its individual line of localization, and when both the all the object points then simultaneously stimulate the two fovea, they appear in one and the same respective visual direction. So the this direction belongs to both the right and the left fovea as if there is a central cyclopean line. So every retinal point or area has a partner in the fellow retina with which it shares a common relative visual direction. So A corresponds to A and B corresponds to B, but A does not correspond to B or F. Then the retinal correspondence is retinal receptors in both the eyes that dictate the common visual direction and the binocular condition are called corresponding retinal points. So A and B are the corresponding retinal points. Then normal retinal correspondence is fovea when corresponds to the fovea of the other eye, and when the nasal element of one eye corresponds to the temporal element of the other eye and vice versa. So what is it? Normal retinal correspondence is when the fovea of one eye has a common visual direction with an extrafoveal point in the other eye, not the foveal, and it is seen if the angle of squint is small and the extrafoveal point is very close to the fovea. So it is an attempt to regain the binocular advantage, and it is anomalous, but it is important because then the image, then diplopia is not seen, and which results in the eye seeing binocularly single in spite of a manifest squint. So it regains the binocular advantage. Then can cover test reveal the abnormal retinal correspondence? So if we cover the normal eye, then the abnormal eye takes up the fixation to the center, and then there is no need to develop the abnormal retinal correspondence. And degree of the squint, the quality of the binocular single vision depends on the degree of the squint. If the degree is small, then the quality is better. Then sensory fusion and motor fusion is also important for binocular single vision, and sensory fusion happens at the level of the brain. So unification of visual excitation from corresponding retinal image into a single visual percept. Single vision is the hallmark of retinal correspondence. So fusion is always a central process and takes place in the visual centers of the brain. So the requirements to sensory fusion are they should be located on the corresponding retinal areas. They should be similar in size and similar in brightness and sharpness. And unequal images are sensory obstacles to the fusion, and they are itself an etiology for the squint. So double vision is a hallmark of retinal disparity when the object falls on the two non-corresponding points of the retina, results in the double vision. So this right eye is shifted outward. So this object, the light rays from the object fall on the temporal aspect of the retina. So the image will be formed on the nasal side. So two objects will be seen. For example, we can see this butterfly, and if we try to put pressure to an eyeball, and then we will start seeing double. Why it happens? Because when we apply pressure to the globe, we are squeezing the globe, and on the squeezing, the object now falls on the non-corresponding points in the retina, so it leads to diplopia. And motor fusion happens so that sensory fusion can, it helps to maintain the sensory fusion. So it refers to the ability to align the eyes in such a manner so that the sensory fusion can be maintained. It is an exclusive function of the extrafoveal retinal periphery, and no stimulus or motor fusion exists when the images of a fixated visual object fall in the fovea of each eye, as we don't need to move the eyes. So the eye was deviated inside, and then the motor fusion is the eye moves outwards and then it falls in the fovea. Horopter is the sum total of all the points in the physical space that stimulate the corresponding retinal elements of the two eyes. For example, we stand in this art gallery, we look at this painting, and all the paintings appears single to us, and so each point, because each point forms equal angle with this visual axis, and this is a visual axis, this is a fixation point, and it passes to the fovea. So each and every point will form an equal angle. So if we join all the points, so a single line will be formed. So the locus of all the points joined is horopter, the points in the space that project on the corresponding points in the two retina. So horopter is a circle which this is a fixation point and this is the center of rotation of the two eyes. So when it is joined, we get a circle which is a Weyth-Muller circle and it is the theoretical horopter. And if the fixation points becomes nearer, then the circle gets smaller. And what is empirical horopter? It is experimental horopter and it is slightly flatter than the Weyth-Muller geometric horopter curve. It has greater radius of curvature and the deviation of the empirical horopter from the theoretical one is Herring-Hillebrand deviation. And why it happens? Because there is more number of the photoreceptors on the nasal side of the retina. So the temporal field of view will be larger as compared to the nasal field of view. Now the Pan's fusional area is region, so this is the horopter. And the region in front and back of the horopter in which single vision is present is known as the Pan's area of single binocular vision or Pan's fusional area. So all objects we saw that need to be present on the horopter, but it says that they need not be present on the horopter to be seen as a single image. They can fall on the non-corresponding points, but they should be present in the Pan's fusional area to be seen as a single. Then the physiological diplopia. The diplopia elicited by an object beyond the parafuture area. So crossed diplopia is temporal disparity and crossed is nasal disparity. So normal individual not observe this diplopia in day-to-day life. For example, if we see a far object, for example a tree, and then we look at the if we fix on the tree, then this is the horopter, and then we look near to some near object, for example, a pencil. So if we, so here we are looking at the far object which lies on the horizontal, and then we start looking at the near object which is a pencil, and then these two start appearing double. And if we close the right eye, then the left object disappears, and we close the left eye, then the right object disappears. So this is crossed diplopia, and if we look at the near object first and then we start looking at the far object which is a tree, then the tree appears double, and when we close one eye, so for example the right eye, then the right disappears, and left eye, then the left disappears. So this is uncrossed diplopia. Then fixation disparity is the minute image displacement rarely exceeding several minutes of angular arc and within the panel space while fusion is maintained. When dioptic stimulation is, it refers to the different stimulation in the two eyes which occurs when binocular stimuli fall on the non-corresponding points of the two retina, and it depends on the degree of non-correspondence. The classes are binocular rivalry and binocular luster. The retinal rivalry, it happens when the dissimilar contours are presented to the corresponding retinal areas, so fusion becomes impossible. For example, one eye is shown these lines and other eye is shown these. That the fusion cannot happen and both the eyes perceive this image. So it occurs due to the competitive interaction between the two retinal channels because there are separate channels for the right and the left eye. So a third binocular channel is activated only by a fusible input. Constant foveal suppression of one eye with cessation of the rivalry leads to. So if we suppress one eye, then other eye leads to the sensory dominance of the other eye, which is a major obstacle to the binocular vision. And when we do the squint surgery, so after squint surgery, the return of retinal rivalry is a better prognosis because it denotes the binocular vision. And binocular luster is the lustrous appearance of surfaces like a waxed surface. Table top appears waxed due to binocular luster, and it results from the different position of partially reflected objects in the surface by virtue of the different position of the two eyes. So with one eye we can see this, and other eye singly this, and with both eyes we can see a waxy surface. The milestone of the basic development. 2 to 3 weeks, the infant turns his head to fixate an object. 4 to 5 weeks, infant can sustain monocular fixation of large near objects. And first 1 to 3 months, superimpose the images. 3 months, the fovea is formed to binocular fusion. And then 3 to 6 months, stereopsis. And development of horoctor and convergence is also influenced by dramatic changes in the eyeball size and orbital position during infancy. Then the theories of binocular vision are theories of correspondence and disparity and neurophysiological basis of correspondence. And older theories are alternation, projection, motor, and isomorphism theory. So, correspondence and disparity theory is simultaneously stimulating the corresponding points transmit single visual impression, and a simultaneous stimulation of two objects that differ in the character results in binocular rivalry, and diplopia occurs when disparate elements are stimulated by one object. Neurophysiological basis is out of the binocularly driven cortical neurons, 25% are stimulated equally from each eye, and stereopsis is related to horizontal disparity, sensitive binocularly driven cortical neurons. Then the abnormal binocular vision is confusion, diplopia, suppression, eccentric fixation, abnormal retinal correspondence, and amblyopia. So confusion, diplopia is mainly seen in the visually mature systems, because visually mature system is the kids which are less than 9 years, and because they have enjoyed, they can develop various other adaptations. So confusion and diplopia can be suppressed in them, but the mature system cannot suppress. So confusion and diplopia in the mature systems, and suppression, fixation, and ARC and amblyopia in the immature system. So confusion is simultaneous appreciation of two superimposed but similar images. So for example, this is falling on this fovea, and this image is falling on the fovea of this eye. These are the corresponding points, so we will see both the objects in a single space. And in patients with tunnel vision, or in patients with the advanced glaucoma, the peripheral vision is lost, so they cannot suppress the fovea of one eye. So they experience confusion practically, because they have the constricted field of vision, so they have no choice other than to project to the fovea or to the central area of the retina. And diplopia is simultaneous appreciation of the two images of same object which is falling on the non-corresponding points. For example, this eye is related inwards, and it is falling on this fovea, but it is falling nasal to this. This is falling nasal to this fovea, so the image will be formed temporally, and we will see two objects. Diplopia is more common than confusion, and then uncrossed and crossed diplopia. So if I is in ESO, then we will see uncrossed diplopia. If I is in EXO, then we will see crossed diplopia. Then suppression. So to combat the confusion and the diplopia, we have the kids have central and the peripheral suppression. So when presented with such signal presented from one eye is actively suppressed. This results in perception of signal at a time. This is known as suppression. So central suppression is seen in confusion, peripheral in the diplopia. So central, because it was falling, this was falling on this fovea, and this was falling on this fovea. So we'll suppress one of the fovea, and this is central suppression because fovea is suppressed. In peripheral suppression, one abnormal, the extrafoveal point is suppressed. So this is peripheral suppression in diplopia. And in suppression, you'll see two scotomas, and if the angle of deviation is larger than these two scotomas coalesce together, this is due to the central suppression, and this is due to the peripheral suppression. Then the clinical type of suppression are non-alternating and alternating suppression. In non-alternating suppression, the dominant eye predominates over the image of the deviating eye, and it leads to amblyopia because it is a dense suppression. And in alternating suppression, the two eyes keep switching the suppression. So example, if the right eye is fixating, then the left one is suppressed, and if the left is fixating, then the right one is suppressed. Then we have already seen abnormal retinal correspondence. And then there are two angles, objective and the subjective, objective angle and subjective angle. Objective is the motor deviation, how much the eye deviates so as to see a normal a single object. So this is seen from outside, and subjective angle is from the phobia to this point. And this is harmonious abnormal reticular correspondence, and this is unharmonious abnormal reticular correspondence, because uh, this angle and this angle is not equal. So if we try to correct it, then if we introduce a prism in between this, the prism is face out, because this arrow should be towards the deviated side, and then the rays fall on the fovea. So now the patient completes diplopia after correction. So it can happen after the, so it is known as paradoxical diplopia. It can happen also after the squint surgery, and it takes 4 to 6 weeks to disappear. So we have to take proper contact. Then abnormal reticular correspondence is not same as the eccentric fixation. In eccentric fixation, if we cover the normal eye, so this eye has developed eccentric fixation and its fovea is abnormal. And on covering, it does not move back to its, it does not take fixation, because its another point is forced to take the action of fovea. Then monofixation syndrome, a patient with small angle of deviation less than 10 prism diameter and central suppression present of the non-preferred eye, peripheral fusion is present, and it happens in anisometropia or unilateral media opacity. Then stereopsis is depth perception, and it is the ability to obtain pressure and the superimposition of two images of the same object which are seen from a slightly different angle. So one eye sees this, other eye sees this, but if both eyes are seen, then depth perception is. Then stereoacuity is a quantitative measure of the stereopsis. It represents the smallest horizontal reticular image disparity that gives rise to a sensation of depth. It is measured in seconds of half. 1 degree is 60 minutes, and normal stereoacuity is 15 to 30 seconds of half. Then perception of depth is distance of objects to perceive the distance of objects from each other. Binocular is stereopsis, and monocular clues are many: parallactic movements and linear perspective, overlay of contours, size, distance from horizon, distribution of highlights and shadows, and linear perspective. So the objects beyond the fixation point, they move in the same direction, and objects closer, they move in the opposite direction. So occlusion, if we occlude, if one object is seen occluding the other, so the object in front is seen closer, and if two objects are of same size, but they are placed near or far, so the farther object appears smaller. And if we put an object close to the surface, then it casts shadow, and a distance to the horizon, the height is seen. The object which is above is seen at a farther distance, and linear perspective is two parallel lines are seen touching each other when seen at infinity. So test for stereopsis and random plot stereogram, it was by PN1 laboratory pencils. When the litmus light test, we will use a Polaroid glass, and we try to see this, and the patient is asked to touch the wings of the fly, and then move to the circles, and then asked to see which circle is seen closest, and then the angle. So that the circles is the fine stereopsis. It shows the fine stereopsis, and these two are for gross stereopsis. And random dot test, there are 3 cards. So this is the relief model to show what he should look for. Then it contains the E, and then it is blank. So both the cards are held at a distance of 50 centimeter, and the patient is asked to indicate which contains the letter E, and the stereoacuity when present can be quantified by increasing the testing distance from the point, and the depth perception is better at the nearer distance. Then the TNO test, it consists of the 7 plates, and first 3 plates are used to establish the presence of gross stereopsis, and the other are for fine stereopsis. So BSA is not inborn but develops in the first decade of the life, and abnormal visual experience results in poorer or no BSP, and reversible only of intervened in the plastic period of development, and a good understanding is fundamental in successive treatment of this anomaly. So there should be sensory and motor fusion, and and there should be no squint and there should not be any opacity or any significant reflective error in one of the eyes. Sense diffusion and equal image clarity should be there. Abnormal retinal correspondence, which is when the fovea does not correspond to the fovea but to an extrafoveal point. So that is also abnormal retinal correspondence, and each point on the retina has its fellow partner in the other eye. So which to which is development correspondence. So that means if A is corresponding to A in that image, and B is corresponding to B, and fovea corresponds to B, but A does not correspond to B. So that means the nasal corresponds to the temporal part, the temporal part corresponds to the nasal part, and the fovea corresponds to uh, sir, in smaller angle of squint, in smaller squint, it is important so as to see binocularly. If it does not develop, then we will be seeing double images in patients with which have smaller squints, because in patients with larger angle squint, with the developed neopathy, extra एक्सेंट्रिक फिक्सेशन में है कि फोबिया एबनॉर्मल है, तो वो फोबिया मतलब वो वाला फोबिया काम ही नहीं कर रहा, तो अदर पॉइंट इज फोर्स टू टेक अप द एक्शन ऑफ फोबिया, तो वो एक्सेंट्रिक फिक्स करेगी ही नहीं आगे। सर कवर टेस्ट करने पे कवर टेस्ट अगर नॉर्मल आई को कवर करेंगे तो जो है एक्सेंट्रिक फिक्सेशन में आई विल नॉट मूव बैक, एक्सेंट्रिक फिक्स नहीं करेगी, एक्सेंट्रिक ही रहेगी जैसे रहेगी और उसमें मूव कर जाएगी आपसे। सप्रेशन होगा, कंफ्यूजन के लिए है तो सेंट्रल सप्रेशन होगा, एंड सेंट्रल सप्रेशन एक एम्ब्लायोपिया हो जाएगा अगर कांस्टेंटली सप्रेस है चिन हेड टर्न उल्टा उल्टा हेड टर्न आई की किधर मूव करेगी, हाँ IRC abnormal retinal correspondence Yes, मैम वो सेम ही चीज़ है कि both the eyes when see singly तो ऐसा कि एक सल्यूबिन आई सेंटर पे है जो एक ऑब्जेक्ट देख रही है मतलब एक सिंगल आई में एक ऑब्जेक्ट देख रही है दूसरी if they fuse also they see one single object so that is एक आई in the center ऐसा मतलब मान लिया image